I do Q&A here, chat over here, participants over here. All right. Nobody.
Oh, please.
It seems to me like.
Sorry, what? Amelia?
Oh, nothing, nothing. Have you shared? Have you started a session already?
Yeah.
Okay.
I feel like the experience is less severe, less threatening.
And it's very comfortable. It's not uncomfortable like the jail used to be.
The old way was much more complicated. It entailed putting goop in your mouth and pushing it hard and making an impression, and it wasn't particularly comfortable.
I always show the patient afterwards what we just did, because they ask me, well, what are you doing and what is that? And they're quite amazed every time they see the screen. Yeah, they love it.
It's amazing. It's very, it's in color, and and it moves, and with a little switch, they could just make it go up and down and around. It's amazing.
Fast is always better in New York.
Am I that busy? Am I that busy? Yeah, I'm that busy. Yeah, I'm a New Yorker. We're busy people.
Well, number one, when you're going digital, you really need to assess your technology in your office and see where it's at. Are your computers updated? Bring in your IT company so that they know, they can assess what your needs are. When you talk to the company as far as the iOS scanner that you're going to get, have them also evaluate, say with your IT company, that you have all the right specs, involved. I mean, if you have 5 generations back, it's probably not going to be a fit. So, you have to upgrade your physical plant first. Then you're going to move into going into this technology. And then with this technology, you're going to have to find, what kind of footprint that you want. Do you want the big cart, or do you want a more mobile cart with a laptop? Do you want corded versus uncorded? Do you want color? Do you want black and white? It's just, or mono. You have to make that decision, which way. And the only way you're going to do that is by, having the rep come in, and you're going to try it and see where it's at. Then obviously you have to talk to your team and explain to them, this is where we're going to be going, and we're going to have an implementation process. And you basically have to have a plan. You want to have a plan like you have with anything on how we're going to incorporate this technology, and then you're going to implement it. And then you want to make it, again, it's something that you have to do on a daily basis. With this type of of technology because it's a core technology in dentistry. It has to become a routine. And the only way to do routine is to do it on a daily basis. And, you know, we're still evolving on this. It's not going to happen, you know, in a month. It's going to take a little time, but, you know, just you're going to be making progress from the beginning. And so you start off in the beginning by taking diagnostic study scans from any new patients that come in. And then you start building it up from your current pool.
Today, more and more digital equipment is being used by dental practices. For example, the patient management system is computer-based. When you take an X-ray or use a camera for intraoral examinations, these files are saved to the digital patient journal. And also, with TRIOS, you can take digital impressions of your patients. Taking manual impressions is a key step in the dental practice. Using impression trays and impression material is perceived as being accurate enough and as an ingrained work process too. You are probably an expert on taking conventional impressions, but with a digital impression you gain so much more than just the impression. Let's take a look at some of the beneficial opportunities and increased potential that comes with introducing a digital intraoral scanner into a dental practice. Patient care is key. A digital scan can be performed in minutes and is more comfortable than having your mouth filled with impression material, so you can better assist gag-sensitive patients. Happy patients mean more patients and greater patient retention. Digital scans are also an invaluable communication tool to talk about oral health care and potential treatments, making it clearer why patients may need treatment or why and where they need to focus their attention when taking care of their oral health. The accuracy of the digital impression is much more precise, and it reduces the need for retakes, because you can see the impression on the screen in real time. A proficient intraoral scanner user following the correct technique can achieve highly accurate results with minimal adjustment consistently, leading to a more predictable outcome. The collaboration with the lab improves, as digital impressions can be sent almost immediately, and with many labs already using digital software to design, the outcome is higher quality, which results in better patient treatment. Digital impression taking and intuitive digital workflows enable the dental practice to optimize the time spent on a patient. This is time that can be spent on seeing more patients or for extended patient care. The digital impression is less time-consuming when preparing for the impression, taking the impression, and also finally cleaning the impression trays. The savings are not solely based on time, but the dental practice will save on impression material, shipping impressions and models to and from a dental lab, and in general the handling and storage of models. Hygiene and cross-infection risk have never had more focus than right now. Traditional impression techniques require handling multiple items, including the impression tray, wax bite blocks, impression materials, and any associated appliances. These handling factors are eliminated with digital impressions. Conventional impressions that are transferred to a lab involve transportation, which increases the risk of cross-infection. Digital impressions do not require any physical transportation from the clinic to the lab. When using a TRIOS scanner, a strict protocol involving thorough cleaning and sterilization between patients ensures that there is significantly less risk of cross-infection when taking digital impressions. In addition to a digital impression or scan being quicker and more comfortable, gathering digital patient scans is an investment both for the patient and the dental practice. This is because digital impressions can be used for monitoring the patient's changing dentition over time. You and the patient can look at and compare all the scans that have been taken. On a more personal note, learning new skills supports your professional development and competences. When was the last time you did something for the first time? Implementing a digital scanning workflow in the dental practice allows you to rethink how you work together with your patients and team to deliver first-class, cutting-edge treatments.
I'm Dr Eduardo, a French dentist. I work in Nozay, France. Using the TRIOS 4 and the Move, we start with the first scan after a clinic check. And then I use the diagnosis and the fluorescent tool to catch the decay, and then I switch with the patient and he's, wow, what's going on? And I told them that we are just taking a new way of diagnosis, and this way I can have a better check. This way I hope I won't miss any decays. So this is different for my patient, but they are very glad and very happy to see what's going on for them, and they understand very easily what's going on. So it's better for them, it's better for me, and I'm sure they are very happy when they leave my office. This way we are working on the dentist chair, so it's very easy for me, and they are watching in real time what's going on. I think it's a better dynamic with my patients, and we are working hand to hand, so it's very fine for me. So for me, Move Plus is a very powerful tool, and every dentist should have it.
fandt det meget inspirerende. Vi blev så inviteret igen nu her, efter at have arbejdet med TRIOS i 5-6 år. Når man lærer den at kende, så sidder du og får nogle vaner, og du arbejder med den, men du kan altid lære noget mere.
Og Dental Desktop Version er en opgradering fra Classic, og den har jeg så haft fået et kursus i dag, og har givet mig rigtig meget, og har addet til motivation. Den skal jeg hjem og arbejde med, det er der ingen tvivl om.
Vi sidder jo hele tiden og har ønsker derude på klinikken. Det her system, så er det jo netop, at det bliver lyttet til vores ønsker, og der bliver eksekveret meget hurtigt på de ønsker, vi har.
Man kan godt se, at det bliver meget lettere, når det hele det bare har flow, og det er bare next, next, next hele vejen. Det synes jeg har været rigtig fedt.
Dagen i dag, den har virkelig budt på rigtig gode input. Også fordi, at 3Shape de udvikler hele tiden. Nogle af de nye ting, Patient Specific Motion og AI, det glæder vi os rigtig til at se i hverdagen.
It seems to me like I feel like the experience is less severe, less threatening.
And it's very comfortable. It's not uncomfortable like the gel used to be.
The old way was much more complicated. It entailed putting goop in your mouth and pushing it hard and making an impression, and it wasn't particularly comfortable.
I always show the patient afterwards what we just did, because they ask me, well, what are you doing? What is that? And they're quite amazed every time they see the screen. Yeah, they love it.
It's amazing. It's very, it's in color, and it moves, and with a little switch they could just make it go up and down and around. It's amazing.
Fast is always better in New York.
Am I that busy? Am I that busy? Yeah, I'm that busy. Yeah, I'm a New Yorker. We're busy people.
number one, when you're going digital, you really need to assess your technology in your office and see where it's at. Are your computers updated? Are, bring in your IT company so that they know, they can assess what your needs are. When you talk to the company as far as the iOS scanner that you're going to get, have them also evaluate, say with your IT company, that you have all the right specs, involved. I mean, if you have 5 generations back, it's probably not going to be a fit. So, you have to upgrade your physical plant first. Then you're going to move into going into this technology. And then with this technology, you're going to have to find, what kind of footprint that you want. Do you want the big cart, or do you want a more mobile cart with a laptop? Do you want corded versus uncorded? Do you want color? Do you want black and white? It's just, or mono. You have to make that decision, which way. And the only way you're going to do that is by, having the rep come in and you're going to try it and see where it's at. Then obviously you have to talk to your team and explain to them, this is where we're going to be going, and we're going to have an implementation process. And you basically have to have a plan. You want to have a plan like you have with anything on how we're going to incorporate this technology, and then you're going to implement it. And then you want to make it, again, it's something that you have to do on a daily basis. With this type of technology, because it's a core technology in dentistry, it has to become a routine. And the only way to do routine is to do it on a daily basis. And we're still evolving on this. It's not going to happen, in a month. It's going to take a little time, but you're going to be making progress from the beginning. And so you start off in the beginning by taking diagnostic study scans from any new patients that come in, and then you start building it up from your current pool.
Today, more and more digital equipment is being used by dental practices. For example, the patient management system is computer-based. When you take an X-ray or use a camera for intraoral examinations, these files are saved to the digital patient journal. And also, with TRIOS, you can take digital impressions of your patients. Taking manual impressions is a key step in the dental practice. Using impression trays and impression material is perceived as being accurate enough, and is an ingrained work process too. You are probably an expert on taking conventional impressions, but with a digital impression, you gain so much more than just the impression. Let's take a look at some of the beneficial opportunities and increased potential that comes with introducing a digital intraoral scanner into a dental practice. Patient care is key. A digital scan can be performed in minutes and is more comfortable than having your mouth filled with impression material, so you can better assist gag-sensitive patients. Happy patients mean more patients and greater patient retention. Digital scans are also an invaluable communication tool to talk about oral health care and potential treatments, making it clearer why patients may need treatment or why and where they need to focus their attention when taking care of their oral health. The accuracy of the digital impression is much more precise, and it reduces the need for retakes, because you can see the impression on the screen in real time. A proficient intraoral scanner user following the correct technique can achieve highly accurate results with minimal adjustment consistently, leading to a more predictable outcome. The collaboration with the lab improves, as digital impressions can be sent almost immediately, and with many labs already using digital software to design, the outcome is higher quality, which results in better patient treatment. Digital impression taking and intuitive digital workflows enable the dental practice to optimize the time spent on a patient. This is time that can be spent on seeing more patients or for extended patient care. The digital impression is less time-consuming when preparing for the impression, taking the impression, and also finally cleaning the impression trays. The savings are not solely based on time, but the dental practice will save on impression material, shipping impressions and models to and from a dental lab, and in general the handling and storage of models. Hygiene and cross-infection risk have never had more focus than right now. Traditional impression techniques require handling multiple items, including the impression tray, wax bite blocks, impression materials, and any associated appliances. These handling factors are eliminated with digital impressions. Conventional impressions that are transferred to a lab involve transportation, which increases the risk of cross-infection. Digital impressions do not require any physical transportation from the clinic to the lab. When using a TRIOS scanner, a strict protocol involving thorough cleaning and sterilization between patients ensures that there is significantly less risk of cross-infection when taking digital impressions. In addition to a digital impression or scan being quicker and more comfortable, gathering digital patient scans is an investment both for the patient and the dental practice. This is because digital impressions can be used for monitoring the patient's changing dentition over time. You and the patient can look at and compare all the scans that have been taken. On a more personal note, learning new skills supports your professional development and competences. When was the last time you did something for the first time? Implementing a digital scanning workflow in the dental practice allows you to rethink how you work together with your patients and team to deliver first-class, cutting-edge treatments.
Hello, I'm Dr Eduardo, a French dentist. I work in Nozay, France. Using the TRIOS 4 and the Move, we start with the first scan after a clinic check. And then I use the diagnosis and the fluorescent tool to catch the decay, and then I switch with the patient and he's, wow, what's going on? And I told them that we are just taking a new way of diagnosis, and this way I can have a better check. This way I I hope I won't miss any decades. So this is different for my patient, but they are very glad and very happy to see what's going on for them, and they understand very easily what's going on. So it's better for them, it's better for me, and I'm sure they are very happy when they leave my office. This way we are working on the dentist chair, so it's very easy for me, and they are watching in real time what's going on. I think it's a better dynamic with my patients, and we are working hand to hand, so it's very fine for me. So for me, Move Plus is a very powerful tool, and every dentist should have it.
Our wonderful world is on pause. Dental practices and labs are quieter, and patients wait patiently in the wings, waiting for that golden moment when we can make them smile again in every way. Make them smile by doing what we do best and building the businesses that are our labor of love. Until then, let's stay together while apart. Let's take the time to learn together. So when the time comes and business resumes, we can make it bloom with newfound knowledge. This way, we can keep changing dentistry together.
Okay, so once again, welcome to TRIOS Day. And I'd like to take this opportunity to thank everyone for joining us for this very special TRIOS Day. Here again, you will learn everything and anything about TRIOS from our experts, the best and brightest from Asia. And in this case, for tonight, we have a speaker joining us from Madrid. Once again, I'm Dr. Lala, Asia Pacific Academy Marketing Manager, for your host for this webinar series. We would like to welcome everyone from all parts of Asia: Singapore, Indonesia, Thailand, Philippines, Malaysia, Myanmar, and Vietnam. We also have participants coming from outside of Asia. Welcome. Again, for the past year, we welcome all participants who are in different stages of digital dentistry, whether you're just considering going to digital, or you just received your first scanner, or you have your in-house lab. Again, everyone will see that they will learn something that they can use in their clinical practice the next day. And we hope that this will be very, very beneficial in your practice. So as we say in the video, let's stay together while apart. But as I've always said, tonight is a very special TRIOS Day because we are celebrating 1 year of doing this webinar series featuring different experts, having more than 5,000 participants all across Asia and the world. So in behalf of 3Shape Southeast Asia, we would like to thank you for your support, and we hope that we are able to guide you in your journey in digital dentistry. And with that, we'd like to thank you with this video. All right, so again, thank you once again for joining us for the past year. And as always, as we've mentioned, for any, we would like to also thank our partners who have been with us for the past year doing this webinar series. And again, for any inquiries and questions, please contact the following partners that we have in all these different countries. And of course, follow us on Facebook for all the updates happening across Southeast Asia. So again, as always, we have some house rules for this webinar series. Feel free to post your questions on the Q&A. We will read the questions at the end of the lecture. Vietnamese translation is available for this webinar. Please kindly choose English and Vietnamese in the interpretation option at the bottom of the screen. Personalized certificates will be given at the end of the session. Please wait for the QR code to be shown after the Q&A, and your certificate will be sent to your email once you complete the feedback form. So again, this is the sample of the certificate that you will receive at the end of the session. And as always, we have been with him for the past year. We have Dr. Hai Ngot Tran translating us for Vietnamese dentists, and soon he will have his own lecture on TRIOS Day as well. Okay, so again, how to access it? Click on the interpretation button at the bottom of the screen. Click on English or Vietnamese, whichever is appropriate. All right, I hope that's very clear. So once again, we'd like to welcome you for this TRIOS Day. Again, very, very special, very, we are so excited to learn from him. So we have our topic for this evening is digital arch, full arch, immediate implant plan loading with digital workflow. And we have with us, of course, Dr. Luis Cuadrado. All right, so for us to start, let me introduce to you Dr. Luis Cuadrado is a dentist and a plastic reconstructive surgeon. He's the director of the I2 Implantology Clinical Center. He's also the director of the postgraduate training program in implantology in University of Madrid. And he's the member of AO, EAO, SEI, SECIB, I hope I'm pronounced, and ITI. He also published over 200 and lectured in over 200 national and international courses and conferences, and wrote more than 100 scientific articles. He has a practice in oral implantology, extraoral, and reconstructive surgery, as well as he's also the author of the book Atlas of Immediate Dental Implant Loading. So I'm sure you're all very, very excited to learn from him. Thank you very much for accepting our invitation. I have been emailing you for the past couple of weeks. Dr. Luis, I hope you are okay.
I'm okay. Thank you so much for your kind presentation. Thank you so much. So, so let me share my screen.
Right.
Let's start.
Hello.
Yeah.
Okay.
Hello?
There seems to be a problem with our
Sorry.
interpretation, so we will figure that out in a short while.
Can you hear me, Dr. Lala?
Yes, we can hear you, Dr. Hai. So
I think it's the wrong
we will figure
channel.
that out in a while. All right, we're seeing your screen right now, Dr. Luis.
Can I start?
Yes, please put it on. Yes, there you go.
Okay.
All right.
Is that correct? Is that correct? The image is the
Yes.
presentation on your screen? Okay, fine. Thank you so much. Thank you, Lala. For me, believe me, it's a big honor and pleasure to be with you this tonight. For you all on all those countries I visit many times, and I'm always surprised of your culture and all your setup. You know, it's amazing, amazing. We love Asia, of course. So thank you so much, Lala, again, and thank you so much, 3Shape, for inviting me to stay with you this tonight. And I want to start saying that we are going to talk about the treatment, the full digital treatment for the patients demanding a full arch treatment. So I think it's the most demanding treatment we can offer to our patients. And of course, there is important thing on the bottom of all the presentation. All the companies are taking advantage of the new digital wave. You know, the intraoral scanner has changed. It means a new odontology, a new dentistry. We can take all the favors we can take from the digital dentistry to provide our patients with the best treatment. It means, for example, this is a picture of a full monolithic zirconia rehabilitation for a full arch with some pink porcelain on it, of course, but everything drives to this situation. All the companies, I started saying about that, all the companies are designing all the elements or the tools involved in this treatment to get the best of our patients. So on the bottom of everything is, I would say the future is really the present. So we are going to talk about the full arch, immediate implant loading with the digital workflow. But the most important thing is that it's not only the immediate loading capability with all the tools and all the workflows I'm going to present you. The most important thing is that it drives to the final prosthetics in a very easy way. As a fundamental, I will say that we always start with the temporary prosthesis, a fixed temporary prosthesis, same day, but we reach the final based on that temporary. We use what we call digital arch. Digital arch is the name we called our different workflows we use to treat our patients. And I will enter on it very deeply. First of all, let me disclose my conflict of interest regarding this presentation, because I am the inventor and the designer of different tools and different devices patented in Europe and some of them in Spain regarding to the digital workflow to our patient. So my presentation is about some of these devices. We reached an award for our Ministry of Science and Technology regarding all these devices and all these workflows. But I want to share it with you to take account during my presentation, okay? So, what's on the bottom of the treatment of a full arch patient? Is everything okay?
Yes, everything all good.
Okay, fine, thank you. What's in the bottom of everything? We are using different workflows. We call it digital arch workflows. Number one are the standard and advanced. I will enter on it later. Number two are the I2 1.0 and 2.0. And number three is the guided digital arch. Those are the workflows we use on a daily basis on our patient. But of course, we need some tools, not only workflows. And all those tools, you know better than me, are the implant we are using, the way we monitorize and we are sure that we can load our implants the same day of the treatment. Of course, the intraoral scanner, of course, the design software and the production method. And on the right bottom part of the screen, there is one of the most important things regarding the full arch treatment, which is the temporary prosthesis. Temporary prosthesis is the key point of all our treatment to reach an excellent and great and easy to do final prosthesis. The temporary prosthesis comes as a diagnostic tool for all our patients. So I'm going to talk about different workflows and different tools to provide this kind of treatment to our patients. What we want is to change dramatically I would say, the life of the patient same day with a nice temporary prosthesis, changing lives of our patients. In the way we work in I2 implantology is to let's make things simple, not so complicated. We have the tools, we have the workflows. Let's make it simple to get a nice result like this. So everything from my side, from our side, should be simple. When you talk, when you talk about a full arch patient, this is a very clear example of what I try to say with simple. This is an old woman with a terminal dentition. In fact, she didn't wear any kind of prosthesis. Some failed treatments with implants, as you can see on the upper. It's almost 90 years old. So she needs a treatment that doesn't invite her life. So we start placing 4 implants in the upper, 4 implants in the lower, and provide her with a temporary prosthesis. Same day. She's rehabilitated and changed the life from the very beginning. But after 4 months of integration, we are happy with the aesthetics, we are happy with the function of the temporary prosthesis, and we just place the order to our lab to mill the same file. It has been milled in in TeleoCAD, in PMMA, just in a monolithic material, in zirconia. Just remove and screw the temporary and place the final prosthesis. It means that this patient has been treated only with 1 simple surgery, less invasive surgery we can provide her, with temporary prosthesis, and only the second appointment, the second treatment, let us say that, second treatment appointment could be just place the full monolithic zirconia on the patient and get a nice smile, a nice function for our patients. So that's our way of working, you know, not always, of course. I'm not talking this is the right workflow to treat the patient with the same as intraoral scanner you have take from your patient in the day of surgery. But what I want to say is that this is simple, this is a possibility, and that's the future. We are talking about workflows, we are talking about tools, about our objective of treatment, but we need to talk about some facts that probably all of you are watching a presentation regarding digital treatment of our patients. So what at the bottom, we have to agree everything to continue my presentation. Okay, full digital has a lot of advantages, from the planning, less invasive surgery with a better post-operatory time. We don't take with open flaps, we don't use conventional impression materials. It's accurate, it's simple, same as a conventional, at least the same that a conventional impression. If we need to make any kind of modifications, we make it, as you have seen on the video, right on your screen. I need to re-scan some part of my scan body, just erase it on the screen and re-scan again. We can take advantage of, for the first time, of immediacy. The delivery is immediate. We don't need anybody taking the impression from one place to another. We are working model-free, of course, most of the times. There is in the industrial production, we have libraries, not only for the scan bodies and all the abutments, but also about the designing. The finishing is much more easy for the laboratory. We can make easy modifications, as I will present you later. And the time of treatment, same day, 1 hour for a single crown with implant studio, for example, guided and design studio, 2 hours for a full arch. That's amazing. It means that our patient is perceiving a real quality treatment, a real change the life of the patient and of the treatment team. So in fact, what is a simple treatment when we use the adequate tools and we use the right workflows. That's very clear. This is one of the bottom we have to agree, everyone, to continue with the presentation. Of course, we start with the medial loading prosthesis. So we have to agree that the immediate loading has the same success rate than the conventional loading. The concept has changed from the concept may be able to the concept is be able, and now is fully predictable. So we can use it with confidence in our patient, provided all the data we need to be sure we can load that implants, we achieve that bottom of treatment, okay? So regarding immediacy, we can be talking about, you know more than me about this, but we can be talking days. Only to say you that same success rate, we need to consider, and this is very important when we are talking of intraoral scanner, the number and the distribution of my implants. Of course, when we are planning our surgery, we are thinking with the panoramic X-ray and with the CBCT scan and on the combine scan, we are thinking where are the best places for my where are the best places for my implants? What distance is in between our implants? Because it is very important not only for the distribution of the forces, but also for the accuracy of the intraoral scanner. The longer distance between the implants, you are more in danger to get a wrong file. The loading, the way we are going to load, if the load, we are making a functional loading or no functional, how is your antagonist? The emergence profile of my prosthesis. If I'm going to use progressive loading, I'm trying to avoid cantilevers with the new implants of 4 and 6 millimeters and reduce the occlusal surfaces and the design of the pontics. What are the static load, the pre-chairs and the passive fit, and the dynamic load? So this is my second bottom important message. We have to agree that we can load our implants with the same success rate that a conventional loading, and we have to take a lot of things in mind when planning the case and when doing this, performing our surgery, to get the best of the treatment, to get the best result. So digital and immediate loading. Then let me enter into the tools we use. We use implants, the way to, in an objective way, to be sure I can load my implants. That's of course, personal feeling is important, but I will recommend always to use the Ostel, the ISQ, take the ISQ level and the insertion torque. Of course, the TRIOS intraoral scanner, the design software, production method, and the final prosthesis. So let's explain something very briefly about that. All the implant companies are reaching to this kind of designs. This is the BLX implant from Straumann, the morphology, and also the micro morphology of the implant. Surfaces, new surfaces that allow us to get better results, even in compromised patients, smokers, diabetics, different kind of patients. This kind of implants are designing from the surface to the morphology, to the connection, to the abutments, to the scan bodies, to the libraries for the immediate loading, and of course for the digital workflow. And not only the implant, but also the way we are placing the implants. We have to use the less invasive surgery we can, because the result of the intraoral scanner, of the intraoral scanning, and also the post-op period of our patient is going to be much better if we perform a very careful surgery. So second is I need to be sure that everything is great. So we need to use the Ostel, get the ISQ level of my implant, and also record the insertion torque of my implants. Sometimes we try to get, I'm going to, because I will explain this slide here because of the noise. Sometimes we try to get a high insertion torque when we are treating our patients, and we are reaching the limit of the biological response of the bone. So with the anterior slide, I will come back to it to show you again. On the left, you have seen different charts with the insertion torque of 6 BLX implants. The upper are in the right upper maxilla. The 3 lower are in the left upper maxilla in the same patient. On the right, we use, let's come back. On the right, we use 1 lead drill less. Okay, not the final drill for the 3.75 millimeters, 1 less. So you can see on the slide that my insertion torque reaches even 60 newtons per centimeter. On the lower, which is the same patient, left side, upper maxilla, we use the final drill, just inserting the implants, and we reach a lower insertion torque. What is the difference between those two approaches when I go and I take my ISQ level? Nothing. I don't know if you can see in your computer screen, but the ISQ levels on both, even if I use one more drill or one less drill, are the same. So let's make the best surgery we can do with our patients, trying to reach at least, I will be happy with 21, 25, 30 newtons per centimeter of insertion torque, okay? But again, it has a lot to say, a lot in common with the designs of the implants, with the modern implants, the design with the screws, the shape of the screws, the number of the screws. There are a lot of things. This was our first tool, was the implant. Second tool, how to manage, how to be sure I can load my implants. And then what can we see about the TRIOS? We are using the TRIOS. We have in the clinic two TRIOS 3 and one TRIOS 4, and we are using on a daily basis in all the applications in dentistry. I will say, to summarize, with complete happiness. It changed our life. We have been using it from 10 years ago, and it changed, and it doesn't finish. It's always a surprise for us. So we are very happy with the results with the 3Shape. But regarding this, we have to take in mind that we need to know all the scan bodies I have to use, the libraries, the accuracy of that libraries. My best advice to you should be to use always the same protocol. Once I am happy with the result with one scan body with the library, don't stop using it. Don't change it. It doesn't matter. You know, it's very important because some companies doesn't have the real, I would say, accurate libraries. Those are different from different companies, from MIS to Vigo to Straumann and another one, okay? And the second one important message here is that when you are planning the position of your implants, when you are planning your patient, I have to think about what will be the final prosthesis material, because it has a lot in common with the scan body I'm going to use, the abutment I'm going to place in my implant, the emergence profile. In fact, if you realize this situation is like a big puzzle, I don't know, is that the correct word, a lot of pieces in implant dentistry that, thanks to digital, now all those pieces goes together and makes the final picture. So regarding the full arch and the passive fit with TRIOS, this is the important message. This is a milled chrome cobalt framework on screw retainer abutments on BLX. This is a patient we treat in the lower and in the upper. That's passive fit. Only with TRIOS, only with intraoral scanner. You don't need nothing more. The key point is to know how to scan your patient, how to identify your errors. The famous learning curve is very easy to achieve. In fact, this patient, this is the X-ray with the framework. Lower are BLX from Straumann, upper are BLT from Straumann, but both are full digital. It came from a medial loading, temporary prosthesis, and then we reach the final prosthesis for our patient. So this makes a completely different dentistry for our patients, for the dental treatment team, including the lab. When you are reaching the final, sometimes we are taking the intraoral scanner, and before making the framework or the monolithic, we are making this clear bar in acrylic milled, and just through them we can see not only the passive fit, but also how the screws enter nicely into your abutment. It gives you a lot of information. It assures you that your file from the intraoral scanner is correct, and the lab can start and go on. To be honest, fully with you, we are using this sometimes only in difficult cases, because for us, the temporary prosthesis, the initial one, we make it in surgery. If we need to change something during the modes of treatment, we are going to make a new temporary prosthesis with T-bases, and it goes as a method of to be sure that everything is correct, and we go to the framework with the final scan. So, third tool, our intraoral scanner, and then the temporary prosthesis. You can mill it, you can print it. It's a matter of time. Sometimes when we are making same-day bimoxillary patient, we are milling the upper and we are printing the lower to finish it quickly. It's now materials from printed are much better than 2 years ago, and I think it's a very positive way to treat your patients, not only on the full arch, also on bridges, also on single units. The temporary prosthesis allow us to go direct to implant or through abutment, and allow to create nice emergence profile for our patients. That's very important, because with the temporary, as you know, we can create some to optimize the papilla and all the aesthetic outcome of the treatment. So temporary is very important in all the cases. But for example, on this case is just before surgery with the patient with the terminal dentition in the upper. We are going to place the implant. We place, I don't remember if it was 6 or 8 implants in the upper, scan the patient, and same day we place a nice prosthesis. This picture of the patient is 1 week after the surgery. With an excellent prosthesis, it changed dramatically her life. But if you realize there is something wrong on that prosthesis, the middle line is slightly on the left, to the left, and the occlusal plane is not so good. So we just say our dental technician, please make a new one to correct all those problems. And this is the more comfortable smile from the patient. We just remove it 1 week later and place a new one. If we are happy with this temporary prosthesis, all the information provided by this prosthesis will be transferred to the final one. That's very simple. For the patient, we can share all the information with the patient. We can take her opinion into account to get a more predictable result. So, what's the way to place the implants? Always use, we try to go minimal invasive. You can go with digital guided surgery or not. You can, it doesn't matter if you go with guided surgery or you are not going with guided surgery. Of course, on the bottom of everything, this is a patient with a temporary prosthesis, and I want to show you the outcome of this patient. On the bottom of everything is that using guided surgery with Implant Studio, which is for me one of the best softwares for guided surgery, allow you to plan your implants on the best way. It's much more accurate than going hands-free. But on the bottom of everything, and my important message here is that you know that mobility, tissue mobility, is one of the worst enemies of the intraoral scanner, especially on the lower. So if we use guided surgery or not, but I try to go flapless as much as I can. Okay, that's very important. I will show you on the last video what we are doing on the lower when we need to open a flap and correct everything to avoid tissue mobility, because when you are scanning with your scan, sometimes when you pass, the soft tissue is in one position and the next pass is in different positions. So the scanner is not going to stitch all that information. So what is my message with this patient? I'm showing you. My message is try to make a very simple surgery, a very conservative surgery. Try to go flapless if you can't, and the best way should be to use Implant Studio, a guided surgery software, and place your implants flapless. That's my message. In this particular patient, this is a dentist. We need to treat also the lower, but we start with the upper. We place 8 bone level taper implants from Straumann, scan, and produce an initial temporary prosthesis. And this is the prosthesis I have shown you. You have shown the video. Let's say that's the last temporary. What we are sending to the lab is of course, the digital file to design the prosthesis, but also the lab has the temporary prosthesis printed. It means that they can mount everything on the articulator, and they can design different type of prosthesis, taking into account all the information coming from the temporary. So in this particular case, he is a dentist, the patient, and we make 2 different final prostheses. The one on your right is a metal framework, thermometallic prosthesis, and the one on the left is Circat Prime monolithic zirconia with prime from Ivoclar Vivadent with IMAX ceramics on top and characterized. These 2 prostheses was made by my teammate Arturo Godoy Senties in Mexico, which is, you can see the quality of his work. He's an excellent dental technician. For me, he's one of the best in the world. But the dentist wanted to have 2 different prostheses, one made in zirconia and the other one made in ceramics. It's difficult to say which is better, but the most important thing for the dental lab is that the one on the right is obviously, I would say, better in appearance than the zirconia one. Slightly better, I would say. It's a 10. Let's give them that a 10, and the other one I will give them 9.5 when you compare both. But the treatment time for the patient, the time the lab used to produce this kind of prosthesis is, let's say, knowing how Arturo works, almost 1 week at least on the right, completely handmade, and only 1 or 2 days on the left on the monolithic zirconia. It means that the lab can take excellent prosthesis, dentogingival prosthesis, with a simple treatment, not only for the workflow and the temporary prosthesis and everything, but also for the materials the labs has now to work with. This is the thermometallic one, nice prosthesis in place, and this is the zirconia monolithic with IMAX Circat Prime made by Arturo. This is the zirconia and the zirconia in place. Excellent treatment for the patient. So we have been talking about that we need workflows. We have been talking about we have some tools, and now let me explain you what is the workflows we are using to treat our patients. What we need are references between the pre-op scan, the study model scan, and the treatment, the surgical scan. We need something in common between those 2 scans, because the lab is going to merge those 2 scans, those 2 files, to design and produce the prosthesis. We need references. Based on that, we have designed different procedures. Number 1, I told you, is the standard and the advanced. When we have some fixed, stable reference in mouth, for example, a non-mobile teeth. Please remember, I'm saying a non-mobile teeth, stable teeth. We are going to extract, but we use that teeth as a reference between the pre-op and the post-op scan. Those are when we are using the number one, which is the standard, and the advanced. If we don't have any kind of nothing in the mouth present in common into the pre-op scan and the post-op scan, we need to place something in mouth to be used as a reference. Those are devices, the 1.0 and the 2.0. I will explain you later the difference. And now we can use also a guided approach with the digital arch approach. The most important thing is that some of them, in some patients, we are using, for example, for the upper one technique, for the lower one technique, or we are using for some part of the surgery one technique and some part another technique. My message here is that you can merge all those techniques together, depending on the treatment time. If you are talking about the final prosthesis or you are talking about the initial prosthesis. This is plastic. This is not stable, but it has some indications. Sorry, this slide is in Spanish, but my message here is that we can use the standard advanced, the I2 device, and the I2 device 2.0. I2 device 1.0 and 2.0 are devices I'm placing in the maxilla or mandible of the patient to be used as a fixed point to merge all those scans. The question is that will be the most, I will say, the most adequate treatment for all our patients. But if I have some teeth, I will use the standard or the advanced. But sometimes we use directly to the 2.0 or to the 1.0. You know what I mean? So even if the patient has stable structures in mouth, a teeth, a crown, something, we go directly sometimes to the 2.0 or the 1.0 I2 device, because it makes things much more simple, much more, I would say, accurate. For example, we can use it in a totally dentulous patient with a complete denture. We have no reference between the complete denture and the post-op scan. We can use it if I don't have a complete denture, but I have a teeth try-in. If my patient is a periodontal patient with a terminal dentition, I can use one of those teeth non-mobile in mouth, or I can go directly to the 2.0, because mobility of the tooth means that you can get a slight round file when merging because of the mobility of the teeth from the pre-op scan to the post-op scan. So I will say the most plastic is the 1.0 and 2.0 devices I'm placing on my surgery, and those are present in the surgery, in the pre-op and the post-op. Also, when we are treating patients with failing implants, with bridges, with failing implants, I have to remove it. There is a mess there, so it's better to place 2.0. There are a lot of implications with guided surgery, and also think on when we are going to the full digital prosthesis, final prosthesis. So different indications. The message is you can use the standard and advanced provided your teeth or your fixed structure in mouth doesn't move nothing. It's better to go much more better to use the 2.0 or the 1.0. So what is the standard? This is a patient. Let me show you some cases. This is a patient. We make in this patient terminal dentition. We make that's the panoramic X-ray, the intraoral scanner with TRIOS, the study model with and without the removable prosthesis. And we also take a face scan and a CT scan. So in the dental software lab, we merge all those files from the face. This is made with the AFT dental system. Use that special device in the frontal part to merge the smile and to merge the face of the patient. So the lab can start designing a mock-up, a model that we can print and use it as I can take silicone and make a mock-up just before the surgery. So with that mock-up, I can take my study model scan to start treating my patient. This is what we want to reach with the temporary prosthesis, okay? So after that, I have my study model scan. Both canines are not mobile. So I place my implants in the upper, trying to go, as you can see, flapless or with guided surgery. On the right video, you can see the post-op scan with the scan bodies and the two canines. So both intraoral scanner from TRIOS has in common the two canines. So having that in place, the lab can use the pre-op, which is the blue one on the bottom, with the post-op and merge easily both intraoral scanners. Okay, they remove virtually the canines. I remove it in the reality, and this is the temporary prosthesis. This case was made in a course. Now we are trying the temporary prosthesis, the passive fit. And because Arturo was here in Madrid with us in a course, he made the characterization of the temporary prosthesis. This is Nexco from Ivo Calvi-Badent, creating a very nice temporary prosthesis. On this patient, we were going to treat also the lower. So we selected a occlusal plane correct to allow us to treat in the correct way the lower. So this is the temporary prosthesis, same day, half an hour took for Arturo to make the characterization, and this is the result same day with a nice smile from our patient. This was done in a course here in our clinic. That's the final appearance of the patient. So she came from this appearance to that one same day. So it's really great. This is almost makes you almost crying when sharing with the patient. Okay, that's the standard one. When we have some teeth, for example, some fixed structures in mouth. But what happens if I need to place implants on those two canines? Imagine I need to extract my canines and place two implants. So all the information has been lost, okay? So this is the advance. The advance is, on the last scan I show you with the implants, we make a copy and we erase with the finger in the computer screen, we erase only, remember please, only the palatal side of the teeth we are going to remove. You can see it on all the pictures in this slide, but only the palatal side. If you erase the vestibular side, your TRIOS lost the occlusion. So the question is to make a copy. That copy of the initial file will have, for example, in this 4 implants. I need to place 2 implants more anteriorly. So I extract the teeth, place my implants, place my scan bodies, make a copy of the anterior of the final with 4 implants, intraoral scanner. I just erase with my finger only the palatal side of the 2 incisors and then start scanning again. Because I didn't move nothing from my scan bodies, the start scanning and stitching all the new file. So I have now a file without touching the occlusion from the intraoral scanner with all the implants. I will show you this video to understand. I have some implants. I need to remove the canines because I need to avoid long span on my bridges. I need to place 1 implant more, for example, as in this case, just making the surgery. Those are bone level taper also from Straumann. I have my scan bodies. I have, remember, the final file from my intraoral scanner with the implants I start placing. And now I make a copy. I have that copy. I place my implant and just with my finger erase the palatal side, as you can see here. I respect the vestibular, just scan, and now you have a file with all the implants you need. That's a very, this is a very, how can I say in English? It's comfortable, I would say comfortable, because sometimes you need to use, when you are performing a surgery, all the surgeons on the other side, on the audience, know better than me that sometimes you have to change your treatment plan, and sometimes you need to take final decisions. So this is a very nice technique. So standard, advanced, and now let me show you some cases of digital arch 1.0 and 2.0. When am I going to use these devices? When I have no reference, like this patient. This is a completely denture patient with a complete denture in the lower. So I need to place the I2 device, which is the white one you can see on the lower. I have two options, the 1.0 and the 2.0. Remember that also in cases of perio patients with terminal dentition with big mobility, you have to go to one of the devices. Otherwise, it's not possible. On the bottom of everything, on the core of this treatment is to make things simple. So this is made in Spain by an implant company called Fiacom. And we have two different approaches, the 1.0 and the 2.0. 1.0 is this one with a small drill, with a bone screw, some devices to insert the bone screw, and scan body. The design of this scan body is very special because this took us almost 5 years to design. Because if you think on the original scan bodies for implants, when you are scanning an implant, your scan body is only 4 millimeters in diameter. Okay, you need a wider one because in the case of the implant, when you are scanning an implant, you are placing on the space, you are placing on the 3D file, you are placing a 4 or 5 millimeters on diameter structure, which is the implant. But in this case, we have to position a whole maxilla. So the points are in the correct place, the design is the correct, at least for us, to be using this. The message is, with a regular scan body, with a regular implant, it wouldn't work in the correct way. So this is the 1.0. It means that I place my bone screw inside the scan body and just place it in the mouth in the patient in a position, of course, when I'm not going to plan to insert any kind of implant. This is fixed during the surgery, and I need to remove it at the end of the surgery. Of course, we all agree on that. This is only for the moment of the surgery, or only when we are going to the final prosthesis. If I'm going to the final prosthesis and I want to copy something, for example, the temporary on the final scan, I would recommend to use this one because it's just for a moment. You know what I mean? Fix, detachable. I will take it, place it, and then remove it at the end of the dental procedure I'm making. This is the 2.0. 2.0 is a mini implant and also a scan body with the same design, slightly different, as you can see. Some drills with the bottom part that doesn't allow you go further when you are placing the implant, and some devices to insert. The most important thing is the longitudinal canal. You can see in the, I don't know if you can see on your left on the screen, there is the insertion device, and it has a channel slot, a longitudinal slot, that you, with that slot, you have to orientate the position of your implant, because the most important thing is that this implant, which is 4 millimeter in diameter and 5 millimeter in length, the connection, which is an internal hex, is slightly different than the regular, because one of the sides of the hexagon is semicircular. It means that the scan body, the digital arch scan body, is going to enter only in one position. It is not possible to place in different positions. It will accept only. So when you are placing your implant in mouth to be used as a fixed point, you have to orientate your slot perpendicular to the occlusal plane in the most favorable position for your treatment. Okay, in that doing that, when you are going with your scan body, it will go in the perfect position. Okay, so this is the 2.0, only one position, perfect fit with one semicircular part in the internal exam. Okay, so this is the kit from the, and let me show you one complete case in the upper and in the lower when we use the 2.0. That's the mini implant. We just open small flap to place the implant and make the study model scan with the complete denture of the patient. Now I have my file with the study model scan with the complete denture and also the occlusion. In that file, I'm scanning the occlusion, and I'm scanning, of course, the I2 device, the 2.0. Now, because this was those are the new implants from Straumann, the zygomatic implant, Zaga, flat in this case, and we are placing 2 zygomatic implants and 4 regular implants in the anterior part. That's the insertion of the zygomatic implant. Our aim of the treatment here is to provide the patient with a temporary fixed prosthesis same day, based on 2 zygomatic implants and 2 BLX on the anterior. You can see I just remove the scan body part of the digital arch of the 2.0 and leave the implant in place. It allows me to work freely with nothing in interrupting my surgical approach to the implants and everything. So I just place 2 implants on the left side, regular implants with a zygomatic, and 2 implants and another zygomatic on the left side. I have my implant, my I2 device implant placed in position. So when I come back with my scan body, I2 device scan body, I'm going to place it in the same position. Okay, so this is the second Zaga flat from Straumann implant. Just placing the implant in the bone. This implant has a flat surface, as you can see, that you can make it flat to the external cortical part of your patient. Okay, now I just place my screw-retained abutments, the multi-unit abutments from Straumann, my I2 device 2.0, and now I have my final file from my surgery. And because I'm using the initial file, make a copy, erase I will go back for you. I place my scan bodies and the I2 scan body, and then I scan with the TRIOS. This is a copy of the study model scan where I have erased the upper maxilla scan. Okay, this new scan preserves the occlusion from the anterior. So I just need to use the 3-point, let's go back, and again, I just use the 3-point alignment on TRIOS, 3 points, and it comes to very nicely to the position the study model scan has. Now my lab has everything and produce a nice temporary prosthesis same day onto the 6 implants. On this patient, we treated first the upper maxilla, and then we are going, this is the CT scan, the patient, same day. And 2 weeks later, because it was his decision, he doesn't want to receive both surgeries in the same way, we are going to treat the lower. Again, small flap, placing the I2 device, the digital arch mini implant. This is the scan body, only accepts one position. This is the position. And now we are scanning as a study model scan, taking the I2 device into the occlusion. That's the pre-op scan. Now I remove my digital arch scan body. I have to regularize everything. This is the case where I'm talking, if you remember at the end, what we are going to do if we have flaps in my surgery. So we need to regularize everything from the surgery to take a the flatter surface for my implants, and we just place 6 implants in the lower, 6 BLX. Some of them were short implants on the distal part. My digital arch implant is in position. I didn't move it, nothing. So when I come back with my digital arch scan body, is going to be in the same position. So insertion, short implants in the distal part, distal to the mental foramina. And now it's very important because, for example, Straumann, we need to use the profile drill to get a nice profile for my implants. And this is the technique we use. We call it digital arch suture. We make a hole, and then with through the hole, we make a suture stitch. That's the stitch. We have placed the scan bodies, and we have placed the digital arch scan body. And now we are suturing with those through those 3 holes. Let me come back. We are suturing. We have the scan bodies in place. Please try to place the scan bodies before closing your flaps. Remember, for example, those are peak scan bodies, are not going to be visible on your X-ray. So we are using the copy. We make a copy of the study model scan because we have the eye-to-device. We use the eye-to-device 2.0 to merge both files. Okay. Now we are trimming the occlusion, and now using the 3-point alignment, 1, 2, 3, 1, 2, 3, same position, 1, 2, 3, 1, 2, 3, same position. Okay. And now we have the perfect occlusion and transmitted to the lab. That's great because it makes everything accurate, everything elegant. You have seen we have placed a cover screw on my implant because I can leave. This is the merging of both files. This is the cover screw for the digital art implants. When I reach this point of my surgery, I can select between remove my mini implant or allow to stay in place. Usually we allow to stay in place because doing that, we can use it for the final file, for the final prosthesis. It means that if I come back on the final file, on the final day, I open a small flap, remove my cover screw, and place my digital arch scan body, I'm going to be able to merge all my files because the digital arch is going, the scan body digital arch is going to be in the same position. I can make a merging between the initial file with the complete denture or with the failing dentition, also with my implants scanning, and also with the final file if I'm going to scan. That's very important. You can select between remove it or leave it in place, okay? In this case, we leave both in place. That's the temporary prosthesis with a small characterization, just placing it. Those are screw-retained abutments for BLX, and we just screw all the screws in place, and that's the final appearance of the patient, of the temporary. That's the case, finish with the temporaries in the upper and in the lower. So I think this is the last. So thank you so much. Thank you so much for your kind invitation, and I'm fully open to all your questions. It took me not 1 hour, so I think everything was clear. As a summary, if you allow me to make a brief summary, this is, for me, this is the most demanding treatment, digital full arch. We need to try to make it simple. This is the way to make it simple. We can trust only in the intraoral scanner to get these results, amazing results that allow you to come directly, not always, but allow you to come directly from the temporary milling in a final material. And for those elderly people, it's just removing and placing one. That's amazing. And we need to manage and to master all the elements, all the tools involved in the treatment. From the implants you are using daily, from the abutments, the scan bodies, the design, your lab, everything has to work as a team to get this kind of result. This is my last book from Quintessence. It's a big, unfortunately, until now it's only available in Spanish, but it's going to be available soon in English because they are going to publish this in the States and worldwide. So I will share with you is more than 3,000 pictures, 180 videos. It's a big, where we reflect everything. So thank you again. I'm fully open to all your questions, and it has been a pleasure. My only concern is that I will love to be there with you, because I love your countries. So technology has this advantage, and at the same time disadvantage. So thank you so much for the great time with you. Thank you.
Thank you very much, Dr. Luis Cuadrado, for your lecture. I really learned a lot. I was writing notes, and I feel that what you've shared with us is very, very nice. You can see you can offer same-day treatments to your patients, and we can really see that you have such an advanced practice. Out of curiosity, this is my own question: do you still do analog workflows, or you're completely and 100% digital?
That's a big question. I will say we are 6 dentists in the clinic, practicing in the different specialties in dentistry, all of the specialties, and I have to force me to remember a conventional impression, being completely honest. So we are almost 100%. It doesn't matter. Also the nurses and the auxiliary personnel has to look for the silicone or for everything. You know, it's a complete different work. When you are able to use it, you never come back. It has no only, you know, in the life you cannot say never, but I will say only some very special cases. But for example, Lala, let me share with you one important thing, because we are talking of a regular patient, and the big problem of that patient is that he has lost 1 tooth or 2 teeth or the whole dentition. But let us think about the patients with Down syndrome or autism, cancer problems, oncologic problems. On those patients, you cannot take a conventional impression. It's like a fighting. It's you have to go sometimes to the surgical unit, general anesthesia, to take some impressions. With intraoral scanner, it's just, you know, it's nothing. We treat a lot of patients with autism, and thanks to Implant Studio, we can take, for example, from we have a lot of cases of that. With simple treatment, for example, to place the patient has lost a central incisor in the upper, and his family or her family wants to replace that tooth. But it means in the conventional workflow to go to the surgical unit, to the hospital, 2 or 3 general anesthesia, a mess, a lot of economic, also from the economic point. With Implant Studio, you take with TRIOS and intraoral scanner, the most small place, you only 4, 5 teeth, like playing with the patient. Then you can take a CT on a moment, and then you can plan your surgery and get with you know, the combination between Implant Studio and Design Studio, and it can give you in advance the temporary prosthesis, what we call guided prosthesis. Is before the surgery, I have my guide, and I have also my tooth. So I just, with a conscious intravenous sedation, with the monitorized anesthesia by the anesthesiologist on the office, you can place your implants in 5 minutes and place your crown in, it's 15 minutes treatment. So conventional impression, of course, it's up to the professional is using, but I can say in our case, it's only the exceptional.
That's true. Well, that puts us into perspective. Honestly, I think what you just said is totally true. How can you do analog now for, you know, patients with special needs and all these different things? I think it really opens our mind to those other. Before it's just convenience, but now it's really necessary, right?
Yeah, completely.
And I think really the importance is the change that it can do to the patients. I mean, for sure it's embarrassing to have, you know, to wait for, you know, the analog workflows and go to the laboratory. And again, it's changing the way we look at dentistry, but in Southeast Asia we are not there yet. And so thank you very much for presenting this, is because you're giving us something to aspire to. All right, so I have a few questions. I have some questions for you. Let me just read them. All right. Okay. So these are questions coming from the Q&A, which we've typed up so that everybody can see the questions. All right. So the first question is, I think this is towards the beginning of your lecture. Why is, I'm trying to rephrase, why the surgery's result came out differently from what we plan in Implant Studio? Is it the error from the 3D printer or the software or the CBCT inaccuracy?
Oh, that's a great question. That drives us to talk for at least one day. So all the elements that our colleague is suggesting could be involved in the error. The question is that first of all, I will try to have the best CBCT. That's very important, without no radiological noise. Then Implant Studio is an excellent, believe me, software for planning. So I don't think it's a fault from Implant Studio. I'm completely sure, because in fact, I mentioned it before when we were talking about all those special patients. What we have a special workflow. We call it guided prosthetics, even for the full arch. I think it's difficult to believe, but with Implant Studio, we can plan the surgery, plan the implants, make the guide, and produce the temporary with the T-base cemented on it to be placed right at the end of the intervention. In my book, there are some cases regarding that. That's very difficult to achieve because our colleague mentioned some of the errors, also from the 3D printer, also from the settings of the 3D printer, the CBCT, and even the intraoral scanner. I think this is the most demanding case. Guided surgery, it's a nice tool, but you have to be sure all the files involved in the planning, all the files, all the settings of your printer are correct. For example, we use, I'm not going to say company names, but we have a printer and we are using to print our guides with the parameters of a different company printers. You have it in Implant Studio. My advice to that would be to use, when you are going to print your guide, use from the, Implant Studio allow you to select different companies and different setups for your guide. So use different and try to reach the point when you are happy with your file. Another things that could happen if you are treating patients with mobile denture with teeth with a slight mobility. You are not going to have the complete merging between in Implant Studio, merging between mobile teeth and the CT scan. If the patient has some restoration that drives you to radiological noise. So all those things are the one you have to take in out to get a nice result. But I only can recommend Implant Studio for all of you out there that can use it for guided surgery, for single unit bridges, and full arch, of course. In fact, I didn't mention it, but if you remember the scan body, the digital arch scan body, the 2.0, which is made in PIC, we have it also available in a radiopaque material. So what we are doing sometimes is to make the merging in Implant Studio, for example, for complete denture, having the I2 radiopaque on the pre-op scan and also on the CT scan because it is radiopaque and allow us one or two of them allow you to make a perfect file. So with that, you get rid of any kind of complication because of mobile tooth or, a lot of,
Right.
as a summary, sorry, you realize I like to talk a lot. Sorry about that. But the question is that a lot of things involved in the accuracy of guided surgery. Guided surgery is an excellent tool. And just to finish, you allow me. what we are doing is placing the implants guided and then scanning with the TRIOS. For us, that's the best approach because going with guided prosthetics is sometimes very tricky. You have to be a real expert with guided surgery. So my advice will be to place the implants flapless with implant studio guided surgery, and then place your scan body, place your screw abutments, screw-tin abutments, and scan with your scan bodies, and wait for 2 hours for the nice file to be produced. Thank you for the question.
Thank you very much, Dr. Luis Cuadrado. I mean, suddenly I remember my professor telling me, what is the most important step? I cannot forget this. He always says, what's the most important step? And then the answer always is, it's the step you're in, because it's, you have to start with first step is correct, right? And then second step, everything is correct, and it all comes together towards the end.
Completely
and I
agree.
think you really have to be familiar with the settings, the data that you are putting in, so that you can really have very accurate result. Thank you very much for answering that.
Thank you.
Next question we have: what are the materials you prefer for making temporary prosthesis and prosthetic materials?
For temporary prosthesis, PMMA, without no doubt. We have patients, we use TelioCAD from Ivoclar Vivadent, milled. It's a nice material. The company tells you that it's only for 6 months, but we have patients with 2 years in mouth because they apparently forget to come back for the final prosthesis. So it's an excellent material, and we don't get these cemented T-bases only on the long run, and it behaves excellent in mouth. Even the behavior of the soft tissue around the TelioCAD, the PMMA, is excellent. We didn't graft most of the cases and allow those cases to heal until it reaches the temporary prosthesis. For making temporary, for that, and prosthetic materials, we are using a lot monolithic zirconia, also from Ivoclar, Circat Prime, and other companies that allow you to make nice and final prosthesis. I will say that if I will say 2 materials, PMMA and zirconia monolithic in most of the cases. If I want to give brutal, excellent aesthetics, I will go with Arturo and another professionals here in Spain. We have a lot of nice professionals also in your countries, handmade, because for me the lab is very important. For me, it's in the key basis of everything. I have a lot of dental technicians friends, because they are on the dark side, I would say, and all the final result is because of them, because the great capability with his hands to make such a nice prosthesis, for me is amazing. I never will be possible for me to make such a treatment. So for temporary PMMA, for prosthetic zirconia, and also thermometallic materials when available.
Thank you very much. It's nice that you are able to find a very good, laboratory technician. As they say, we've had so many sessions here in TRIOS Day about, lab and clinic communication. So it's very good that you recognize the importance of that.
For example, some of the prostheses the zirconia are made by Roberto Vives. Are made by Roberto Vivas, which is a dental technician. He works on a daily basis with us, and most of the work you are seeing is made by him. So it's an excellent and clever CAD/CAM designer, and also an excellent dental technician. And because he's on the next door, we can make such a nice treatment. So thank you. I have to take the opportunity to thank Roberto and Cesar and Monty, which are our dental technicians, their help. Thank you so much.
Thank you for that. Our next question would be, okay, so doctor, when you scan the scan bodies immediately after implant placement, How do you handle bleeding, and does it affect the accuracy of the scan?
Yeah, I understand. I understand I understand perfectly the question. Bleeding, yes, it affects not the accuracy, but the I will say the easiness or the way you can scan. Okay, so it is very important to make a very conservative surgery. If you have some point that is bleeding, it's better to use the surgical unit and cauterize everything and get a nice bleeding. Small bleeding has no problem. We always use anesthesia with adrenaline, and most of the cases with full arch are made under conscious intravenous sedation. It means that the patient is fully collaborative. As you know, this is not the general anesthesia, but that allow us to place to have a nice setup for the scanning. So we always dry everything with gauge and just start scanning. Now you can start, for example, to make an idea, only a full arch in the upper or in the lower, using the right workflow to scan the right path to scan will take about 45 seconds, nothing more. A file you can use. If you want to optimize that file, I would say 1 minute, 1 minute and a half. There is no time almost for bleeding. Only in cases if you have hard bleeding or big bleeding, you need to cauterize. In the other cases, you have, at least in our hands, we have no problem. And another important thing is to remember the mobile tissue. Okay, it's important not to have mobile tissue. The post-op period is going to be much better, and also the scanning is going to be better.
Okay, all right. Thank you very much for that question. Let me just share because there's a lot more. Sorry. All right. So the next question is, okay. So this was a question that made me smile. Where could I buy the device and how much is it?
Thank you for the question. It means that you recognize the utility. So thank you from the bottom of our heart, of all the work involved. I think it's only available in Europe right now, and I don't know if they have plans to release it from another countries, because you know there is a lot of things about regulation and approvals and everything. You know, the question is that I cannot give this information because even I'm sorry because I even don't know how much is it in Spain, but I don't know the way to buy it. Sorry. So I cannot help. I could, maybe it's going to be published in advertisement in the near future, but I don't know really the plans.
I think we will be waiting for it with, with
thank you.
Really just waiting for it, and maybe you let us know when it will be available. But yes, I understand, especially for a device like this,
medical
a
devices.
lot of regulations. Yeah. Yes, but congratulations again for coming up with it. I heard you earlier. It takes 5 years. Took you 5 years to design, and I think it's very, very useful. And I admire,
Thank you
the
so
passion
much.
for this. Apart from all the things you're doing, like writing a book and teaching in the university. So yeah. All right. So please let us know when it's available. I think it would be very useful for dentistry.
Thank you so much.
Next is why the need to use a whole implant to keep that scan body in place. I think just further explanation, especially for those of us just getting into digital.
Why the need to use a whole implant? Oh, that's the important question because yeah, I think I understand. If you use the 1.0, remember, is the one with the bone screw and the scan body. When you place it, if your assistant during the surgery is going to use, for example, a retractor, as I show in my surgeries in the videos, you have the possibility that it becomes more mobile. You know what I mean? It moves slightly. So when you are scanning again, there is you don't get the right file. So you are working for nothing. You know what I mean? So it drives us a long time ago to design this mini implant. This mini implant is designed exclusively for this application. This is a mini implant with a special design on the connection and the scan body also. So you can place it, then remove place the implant, place the scan body, and then during the surgery to have it removed, the scan body part, and then come again. So we need something that allows us a prosthetic connection, let's say that way, to come back always on the same position. So that's the reason you need, let's say, an implant. In fact, it's not the real concept of an implant. It seems like an implant, but it's not an implant because it's not designed to be loaded. You know what I mean? It's only for this application. So you need the implant because what I want with my treatment is to place always the scan body in the same position if I have left my implant in place. If I remove it, then it doesn't happen, you know? And also, the connection between the scan body and the implant is very tight. You know what I mean? So it doesn't move nothing. It's like when you place a abutment on an implant, it's very tight. I can even give it with torque. So I'm very sure that my I2 2.0 scan body is in the same position. So definitely you need an implant.
I think, again, as you've mentioned earlier in the lecture, it's really for reference, just to make sure it's always in the same place. And as you said, this is only for cases wherein there's some sort of mobility that doesn't allow you to come back at the same place at the same time. It's all about consistency as well, of course, especially for an implant surgery like this. All right, thank you very much for that. And really, you've explained it really very well. Thank you for that. Again, sometimes new concepts, we're really very hungry for that. All right, so thank you for the informative lecture, Doctor. May I know what are your thoughts on photogrammetry techniques for taking digital scans?
Okay, photogrammetry is an excellent technique. It gives you a 3D information of the position of the implants, but you also need to take a TRIOS scan, an intraoral scan, or a conventional impression to have the correct file. So when it drives to accuracy between, if you compare the, I think it's not, if it is, I don't know if it is adequate or not, but I have to say that way. If you compare the accuracy of the TRIOS for the application we are using, you don't need any other technique. But I recognize that photogrammetry is an option, but you need to take the photogrammetry file, then as a conventional impression or a TRIOS impression, and merge everything. I would say it's a very specialized. How to say, because with TRIOS, you can do everything just in one file, just in 4 minutes. Sent to the lab. Remember my presentation at the very beginning. I say that here in our clinic, we want to make things simple. I don't want to make it complicated. For sure, you have another options, but our option is this one because we are doing full arch every day without, I cannot say without no problem, but 99% of the cases without no problem.
All right, thank you very much for that. Yes, I remember you said you want things simple and you want things minimally invasive. And, you know, again, thank you very much for sharing your thoughts on this. Next is, do we need to turn off adjust? I think this is a TRIOS setting, but do we need to turn off adjust to contact when doing manual alignment with the I2 scan body?
No, no. You have to train the occlusal scan. First step. Then you have the 3-point, now TRIOS, you have the 3-point option, and that's all. That's all.
All right. Okay. Thank you very much.
One point only.
Sure.
We are doing it on TRIOS before sending to the lab, but after sending it to the lab makes it again with dental system. You know what I mean? So we make it twice to be sure that all the files are correct. There is an important part from the lab side to get from Roberto, from our lab is called Dental Full Digital here in Madrid. So it's very important that everything has double check. You know what I mean? First in the clinic, than in the lab.
All right. And I guess that's the reason why you have less mistakes. Not perfect, of course, as in any clinic or practice. So thank you very much. That's all the questions that we have. But maybe before we end, we really recognize and very, very honored to have you with us today. And you shared with us, advanced cases as well that we would like to aspire to. Do you have any for some last advice, any advice for people who are watching us in Southeast Asia on how to really get started to digital? A lot of us are already, there's a big surge in people wanting to use it, but there's also an issue with learning curve and adoption. Do you have any suggestions or advice to some of us just getting their feet?
Yeah, my big concern in the clinic is when internet doesn't work, or some of these things. So I always hear about the famous learning curve. The correct way to do things is to select the hardware you want to work for, to get a nice support and somebody that teach you how to do things in a simple way. Don't make things complicated. You can do a lot of things only with TRIOS, with intraoral scanner. So once you start using, you never come back. That's the main message. It has changed dentistry. There is a new dentistry. There is a new dentistry for our patients, and there is a new dentistry for the labs, for the clinics, for everybody. I always say one thing. In my life, my professional life, I'm surgeon mainly. So I started with implantology, and I remember when the achievement of the osseointegration, that was in implants a big wave. It changed the implantology, and now it's digital with the intraoral scanner. This is a new implantology. So my advice, to be confident with the company, get the support from the company, get the best teaching with your key opinion leaders there, and just enjoy, because this is something to enjoy. I'm lecturing with you right now, and I'm enjoying a lot because I remember the faces of the patient, the happiness, the everything. So it's amazing. So join this amazing journey as soon as possible.
Thank you very much for that. And I agree. A lot of people want to get into it, but there's a little bit of hesitance to trust in the technology.
There is
and I think
in terms of trusting, no doubt. There is no other way. As soon as possible, join this way. Yeah.
Really, I think you provided us a lot of inspiration tonight, and thank you very much again for joining us. And again, as you've said, time to join in and really don't get left behind as well. And I think we can see also the passion and excitement that you're in your eyes and in your voice when you were sharing with us. And I think what's really important as well as a dentist is the impact and the change that we can see in our patients.
You are 3Shape is changing lives. It's all the companies involved, not only 3Shape, but 3Shape is doing really great things, and this is changing the lives of our patients. Something to have it in mind. Remember the patients with Down syndrome, oncologic patients. That's a big part of the population. So thank you, Lala, for giving me the opportunity to be here with you again. I'm looking forward to be there, because I love all those countries. Believe me. Thank you so much.
Thank you very much, Dr. Luis. And again, as I've said, there's no other way to end our TRIOS Day. Again, and celebrating our 1-year anniversary with no less than Dr. Luis Cuadrado. And with that, we'd like to present to you a virtual certificate from us in 3Shape. And we'd like to thank you for sharing your expertise and valuable knowledge in your lecture, Digital Arch, Full Arch Immediate Implant Loading with Digital Workflow. This certificate is signed by Georgia Hinton, International Markets Manager in TreeShape, and of course, our very own Southeast Asia Manager, Jarvis Wong. Thank you very much, Doctor, for joining us this evening. Really a very nice way to commemorate our 1-year anniversary.
Thank you. Have a nice night, evening, and you know where your home for all of you is here in Spain, in Madrid. Thank you so much. Thank you so much.
For sure. Thank you very much. And again, for all the participants, we invite you to join us on TreeShape community for everything and anything about TRIOS. You can see, you can search for anything, scan bodies, whatever you would like to learn more about. There's a lot of training on TRIOS, on the different software. Again, a lot of the different resources, downloadable PDFs, downloadable videos for anything and everything that you would like to further know. And also, we would like to invite you to TreeShape Next, which is a Southeast Asia community, digital community for TRIOS user. Just scan the QR code for this. With TreeShape Next, you have exclusive access for TRIOS users, tips and techniques, direct access to us. And of course, as I've said, this evening, I'm sure you've known her already. We are joined by Amelia Tan, who is our Southeast Asia Clinical and Training Application Specialist. And there's also, again, a way for you to unlock your TRIOS. Again, for any other questions, please contact our partners in TreeShape Southeast Asia. We have Fundaco, Stroman, Henry Schein, DSC, Bio3D, Austin, Vietnam, T Dental Lab, DOE, Longhai, G-Dent, Shua Denti, and Udom in Thailand. Follow us on Facebook again for the next TRIOS Day. And again, in behalf of TreeShape Southeast Asia, we have Jarvis Wong, our Southeast Asia Manager, Amelia Tan, Dr. Hai, who has been with us for over a year already. And of course, this is Dr. Lala Sanchez signing off for the first year of TRIOS Day. There will be more to come. And with that, we'd like to share with you our QR code for this evening's webinar. Thank you very much and good night.